You know, looking at the oncology service line has really been probably my biggest erudition of cancer care. You know, it's not all one person. It's not a physician and a nurse and the patient anymore. It is multiple lines of people involved. And looking at my president's theme, really looking at prescription for cancer care delivery, you know, through collaboration, education, and compensation, the goal was to really enumerate on a lot of these different layers of the actual healthcare personnel team who are interacting with patients in the oncology service line and also distributing information to those patients for the best outcomes, right? Because we want to take care of the patient, and that's our goal in the cancer center. Whether it's a community-based practice, a larger-based community, comprehensive-based practice, going up to NCI designation, academic facilities, into integrated delivery networks, regardless, is to develop outcomes for patients. Learning through this process of my president's theme, the biggest thing has been understanding all of the people involved and some of the niches that have been evoked because there's been a need. For example, looking at oncology psychologists, so psychologists who are focused on oncology, addressing the patient's needs. And there's a numerous area of distinction there which actually may not have evolved at other sites. We have also seen roles, for example, for our nutritionists who are a pivotal part of the cancer care delivery, addressing our patients' nutrition and also how they're going to actually be handled throughout their course of care. In some cases, some chemotherapy can even induce cachexia or a loss of appetite. So how do we deal with that? Do we do it up front or later on in therapy? So really making sure we enable some of these newer therapies with these other parts of the cancer delivery system. Myself, a pharmacist, of course, I'll always kind of talk about that, but even for us, well, we don't have a method for compensation in these because we don't actually have prescriber status. So layers are involved where we see a lot of uncompensated care in that delivery service line. And that doesn't mean we're asking for money or looking at compensation, but it does mean that we have to earmark the time devoted to patients, the time devoted within the healthcare system that we actually impart upon the patient during that period. So really addressing the overall goal, the overarching goal of who's involved, and then making steps for delivery of services involved so we can provide methodologies for patients in that cancer model with our team members. But also what had evolved from this too is we developed a matrix of information, almost like a checklist for diagrammatic workflows of who's involved based on size of a cancer center. A novel approach, because not only does it create an auditing system for your comprehensive cancer center based on size, it also provides benchmarking as well, which can help develop practices, almost homogenize some of those actually process pieces, implementation of personnel, and other areas as well. And that's what we did from that standpoint. We hope as time goes on, we can kind of merge some of these pieces, but the aspect which I find most interesting from the actual time for my president's theme is develop of a matrix. That matrix in itself actually may provide payer information for what they expect in terms of cancer delivery. If you're a certain size, what is your payment model? Do you have the accessory service lines? Here's what your payment is based off of, because they can provide outcomes which may be more improved in certain things as well. So this was a first step. It was probably the first time we've ever seen an overall kind of higher level view, that 10,000 foot view of what we expect to have cancer centers in terms of types of care or services, and that will help address patient outcomes, especially as we're moving more towards other APMs, alternative payment models, OCM, oncology care first. When we start looking at all those additions, how we actually have those paid for. And sometimes certain payment models may give certain payments to help pay for that or defer the cost, but the overall cost of care, do we get compensated to continue those service lines?